radiologist in radiology department. I'm also your year 4 coordinator. So today I'll be delivering a common lecture on topic principles of X-ray diagnosis. Most of the content of this lecture might not come out in your exam even, okay? But try to gauge the concept and principle as much as you can. Some of the content within this lecture is physics related, but you're not meant to know that deep, okay? And as I speak, anyone wants to interrupt me, just you can just shout out lah. All right, so a little bit on history. I'm not sure if this is a general knowledge or not, but X-ray is basically discovered by chance, okay? It was not planned. It was discovered by chance, okay? And when it's discovered by chance, the discovery of X-ray itself is made by this German scientist Wilhelm Conrad Röntgen in the early 1900s. Okay, what happened at this time was he was a scientist himself, a German scientist, studying conduction of electricity through gases. And beside him, somewhere near, there was another table with a fluorescent screen. And when he conduct his experiment, suddenly the fluorescent screen starts to glow, starts to shine. So I was like asking, what is this? This is something new. I believe that along the way, with a good intent of curiosity, he studied more, he experimented more, and eventually this is what comes out lah. The first radiograph. This is very historical X-ray image, the oldest ever. Okay, if you can put yourself in that era, it's the 1800s, yeah, and early 1900s. Probably the Victorian punya surrounding at that time. Okay, you just imagine all the while we are seeing our hand with skin on it, right? Unless you're a physician, you are treating someone with a open fracture. You practically you would never have seen how a bone looks like. Okay, because it's covered with all your soft tissue, your skin. But because with the revolution of X-ray, and an image is able to be produced, you can see that how delighted people at this time actually when they were able to see and look through their own bones. Okay, I think that at this time a lot of people will be very delighted, yeah, as opposed to now lah. Okay, but this image is Sir Röntgen's wife's hands. This is the ring finger. The opacity seen here, not so well delineated as how it should be in our current technology, our era. But this is of course the wedding ring lah. But this image has helped Röntgen to climb up to fame and helped him win the first Nobel Prize Physics 1901. Okay, so what is X-ray? X-ray basically is radiation, and you need to know the basics because I want you to know what you're dealing with. You are going to be the ones who order this thing, okay? So it's basically it's something that you cannot see, okay? If X-ray is something that you can see like red color, green color, and things like that, it will be easier, right? But the thing is, it doesn't have color, it doesn't have smell. We only can see the effect that it does, okay? So it has some element of electric, it has some elements of magnetic in terms of energy, and very much it behaves like light rays, but at the expense of more penetrative than light rays, okay? And when I say more penetrative, it means that dia macam tsunami lah, okay? Kalau you buat you punya graph tu, dia punya the wavelengths will be short. In 1 meter, there will be probably what? How many times as compared to light rays? It's like your waves by the seaside only, right? Like that. Okay, but no matter how penetrative it is, it still can be blocked by dense material. For example, the walls. The walls, it is still. That's why in our radiology department we have CT scan next door. okay? But we do not have to put a lead shield at our walls because X-ray is blocked by the bricks. But just so you know that this X-ray has contributed. This X-ray, including gamma rays, we should be talked more by Dr. Shahri in your nuclear medicine lecture later. Has contributed to images that allows you as a doctor to give a diagnosis. So I just want you to know that all this range of modalities actually utilizes ionizing radiation. Okay. X-ray, scintigraphy, CT, memo, and angiography. Okay, scintigraphy is anything related to nuclear medicine lah. Okay, big difference between scintigraphy and other X-ray based modalities in the department is the source of the radiation comes from the machine. It shines on the patient, and there is something else to capture the image from that. Okay, your detector ke. But different as in scintigraphy, you have radio tracer material that emits radiation, and then you inject it into the patient, and then that radio tracer that is emitting X-rays flows into the blood flow, goes to the normal physiological process, goes to the kidney and stuff, and depending on the type of radio tracer, it will reside in certain type of organ, for example, thyroid and stuff. Okay, that's the main difference. And then the gamma camera, mainly the machine, the gantry mainly tries to capture all these dots of radiation from the patient. Okay, because the patient has been injected. Okay. So what is this? This is not Earth and orbits, but rather this is to show you the different types of atoms that is present in our body. Okay, mainly because we are human, I think 80% we are composed of water. So H2O. So hydrogen and oxygen are very plentiful in us, including carbon, right? That's why we have the carbohydrate CH2, COH and stuff. So what happened is that when a patient is being struck by a radiation, by X-ray, all of these atoms are similarly struck by X-ray. You see it that way. And it's not just the patient, but all of these atoms. And what happens is that all these atoms initially, the hydrogen ke, carbon ke, oxygen ke, all these, they are in their stable state, okay, initially. But X-ray production happens when the X radiation actually hits and dislodge one electron out from its orbit. And that will be different. And if you can think logically, if you remember your periodic table, your chemistry periodic table, as the number increases and the atomic number and stuff, actually, when we radiate that thing becomes denser. That's why your hydrogen in periodic table, the value is what? 1, right? And then oxygen is 16. H2O. Carbon is 12, something like that, kan? So it's about the low range number of the periodic table. That's why when we give radiation to the soft tissue, you do not see much an opacity, as opposed to if you give radiation to bones, calcium I tak ingat berapa, probably 40 something if I'm not mistaken. So you just imagine, bila dia banyak atomic number, the orbit outside the nucleus will be a lot, right? If you still remember, 2, 8, 8, 5, 2, depending on the number of orbit. So the more orbit they have, the more electron they have, the higher the atomic number, the higher the electron number. So there will be more of this reaction going on. When there is more of this reaction going on, that will produce a denser image. That's why bone appear denser than your soft tissue. Alright, so the imaging modalities. Okay, when you come to the department, welcome to the department. Okay, ionizing radiation, just remember all this. Okay, And when I say all this, it means that only in all these modality or images that you see during your word rounds, during your exams, you are able to describe them as lucency, opacity, hyperdensity, hypodensity. Okay, is anything related to ionizing radiation, you can describe them as such. But when you go to your non-ionizing radiation, like your ultrasound, your MRI, never ever use that word. Never ever use high density opacity, okay? Because the principle of ultrasound is different. The principle of ultrasound is basically sound wave. That's why we use hypoechoic. That's a word, the term echo. Echo is sound, okay? Hyperechoic, echogenic. That's how you describe. Nanti dalam you punya OSCE, they will be given pictures, images. Please remember this advice, okay? And as opposed to your MRI, the principle of MRI is not radiation. It's about there's a strong magnet. The strong magnet that spins. Again, it spins all your hydrogen, oxygen. And because all these have different weights, molecular weight, it spins differently and then returns signal differently. But the principle is not radiation. It's the principle is basically magnets. This one will give you signal, hyper intense signal, hypo intense signal. Okay, remember that. Okay, so what is ionizing radiation? Any type of particle or wave that carries enough energy to ionize or remove electron from an atom, dissociate molecular or alternative structure. Okay, basically what this image is going to elucidate is when it has a capacity or potential to ionize, it means that removal of electron will occur. And when you remove an electron, you are changing the state of the atom from a stable state to an unstable state. Okay, this is where your reactive oxygen species comes from. Okay, all those added yang which is a precursor to cancer comes from. That's how cancer. That is the basic of how cancer happens after after irradiation. Okay, so that you can relate back that one of the long-term effect of radiation, if it is used unnecessarily, it is not judiciously used, it will. These are the effects, and even for example, for pregnant lady, okay, what are the effects to the growing fetus? Now, these are the effects that can occur because of the ionizing property. So, for possible effect, may pass through, does not damage. Number 2, may damage, but still your cell is, Allah made your body capable of repairing, so it repairs to damage. 3, it damage the cell, damage not repaired, cell replicates, but in a damaged form, which leads to cancer. And 4, the cell dies. This is what happened if you watch Chernobyl and all those things, how people with radiation toxicity and how they eventually die because one thing that I can remember most is because their colon and small bowel. Actually, as we eat, as we drink, there'll be a continuous process of cell turnover that continue to repair the damage. But when somebody is being radiated by high dose of radiation, the system that is in place to repair the damage is gone. Okay, and as time goes by, your body is not able to process water, food, all your cell metabolism, and that's why the patient with radiation toxicity will eventually die slowly and in a very painful way. So where is it from? Why do you need to know this? Okay, this is a very worthy slide, but what I want you to know is do not scare off the patient with radiation. Okay, if you are being presented with a patient who is concerned with a risk of cancer just because of doing CT scan, you may find you can always explain that actually X-ray is everywhere. Okay, it's not just the source of X-ray is not just from X-ray machine, CT scan, your angiogram machine. No, the main source of X-ray is actually the outer space, your sun, the black holes, and supernova. That's why pilots, stewardesses, they are flying high up in the sky. They are exposed to very high radiation because they're closer to space. Okay, but what we have in our X-ray machine is a man-made X-ray tube. Okay, it's a vacuum tube. Use high voltage. Basically, it does what the process that just now Sir Ronjan did. Basically, there will be electricity involved. Okay, there will be electricity involved, which will accelerate the electron to a high velocity. It hit the anode and create X-ray. Okay, but this process is actually very inefficient. So that's why X-ray tube must be designed to dissipate the excessive heat. Okay, and we have in the X-ray machine we have something that we call X-ray filter. Okay, this is all just for you, good for you to know. Okay, basically filter is the thing inside the film that helps in the machine that helps to absorb the low energy X-ray, the unwanted, those X-rays that does not contribute to the image. Okay, so this is basically how an X-ray tube looks like. This is a schematic presentation lah. How we give electric positive to negative. Okay, this is your filament. The filament will be heat up, and this thing will be rotating. It's a rotatory anode. So when X-ray comes here also the filament also is some type of metal. I don't remember what that. If I'm not mistaken, tungsten or something. Tungsten, and the same thing will happen just like when you radiate somebody or something with X-ray. There's some reaction that will occur here and hit the anode. Anode also made up of special metal, and X-ray will be produced from a thin window, and there will be collimator. Collimator basically means dia boleh tutup buka kan. Tutup buka, you can collimate up down, collimate side to side, so that you just expose the certain part of area. Okay, that's why for example your spine radiograph, you can see the collimation is very thin, kurus kan, but our interest is only the spine instead of the whole body. That's called collimation. Okay, so X-ray production, again, these are how it looks like lah. But just for you to know that actually heat contributes 99%, and the radiation that contributes to the image is only 1%. But with the technology and advancement now, our X-ray tube is very good that it can dissipate all this energy, all this heat. Okay, so this is your baki lah, basically your baki. If you come to the department, you see where they put the X-ray machine on the patient chest, for example, and then expose to the certain body parts, and there will be a detector down here to capture all the radiation and process it into image. Okay, so like just now, what happens to cells, to radiation, it may pass through all of them. Some of them might be absorbed. Okay, but specifically for those structures that are dense, they are opaque, for example bony structures, there will be complete absorption. Okay, absorb most of it. Why? Because just now I told you bones are composed of calcium, high atomic number, a lot of that process going on, so almost complete absorption. But some of them will be useless, scatter, it increases the patient dose but does not contribute to the image. So X-ray penetration principle. Okay, how should I explain this? Okay, just now, I think at the beginning of my lecture just now, I have explained to you how the different atomic weight different atom, carbon, hydrogen, oxygen, and even if the patient has a metal bracelet or ada pakai susuk ke apa-apa kan, all those things are dense, okay, hyperdense. Most of it is made from metal, so it will have higher atomic number. If you check your periodic table, your metal will be at a higher atomic number. Okay, so this explains this one lah. If you see lung mainly it's composed of gas, right? Gas, oxygen, hydrogen is only one, oxygen 16, kan? So it's low atomic number at this region. That's why you get a darker, you get more of a lucency, okay, as opposed to bone, which mainly composed of calcium, higher electrochemical process going on, so you get a more opacity, and the soft tissue will be in between. But apart from atomic weight that I have mentioned just now, there's another factor that contribute to the different appearance of the image is tissue depth. Okay, tissue depth. For example, you're taking abdominal X-ray, for instance. You compare with hand X-ray. Okay, very different, right? Very different thickness. Especially if our tummy is not that flat, it's very different thickness. So as opposed to hand, your hand is very thin. It's not very thin, like it's a relatively thin structure as composed to your abdomen, kan? So that is why when we compare these two images, actually, if you look at the soft tissue of the hand, for example, is very much loosened as compared to the soft tissue of the abdomen. There's a lot of soft tissue in the abdomen. Yeah? There's your mesentery, even though there's some fat, which is there are fat layers which are supposed to be loosened when radiated by radiation, but because summation, tambah, because the summation of all the different layers of tissue depth that I've mentioned just, so the skin, the subcutaneous tissue, the omentum, and then the mesentery, and then the bowel, so on and so forth. So you get more of a density. You see a lot of white and opacity in abdominal radiograph. Okay, this is not taking into account bone structures lah. So image formation, just for you to know that when you come to the department and look at how the X-ray is taken, just so you know that last time we used to use film lah, but now no more. Everything is digital, goes to the computer. But this is how it looks like. Now we have what we call detector. Detector is equivalent to the last time our radiographic film. It has a fluorescent coating, exactly as what happened in Röntgen's experiment, an X-ray film in between. Okay, so these are just the properties of X-rays and gamma rays. Gamma rays. Okay, so what will you see on the film depends on the type of structures and the atomic number, the type of structures, the tissue depth, and the atomic numbers of the structures. For example, lungs, majority is gas, okay, lower atomic number. Muscle and breast about the same, okay. Soft tissue and vertebrae bone will be more of a opacity. So for example, this lateral skull radiograph of a pediatric patient, you can see the bone. The most opaque structure here is definitely this thing here. What is it? Anyone? What is this thing? This is the cochlear implant. It's metal, that's why it's the whitest. It's the most opaque structure. But after that, it's definitely your bones, your teeth, and then only your soft tissue. Never ever forget to review the soft tissue. Okay, whether it's chest X-ray, abdomen X-ray, or limb X-ray, you must comment on soft tissue, even if you feel that they are normal. And then you see air in your trachea, the most lucid. Of course, air surrounding the patient. So we always talk about exposure when we evaluate a chest radiograph, for instance. Okay. So last time when we are not digital, last time X-ray used to be taken old school. They only fire the radiation once, and that's it. They cannot do anything to the image. So that's why they must play around with the parameter of the X-ray very well, which are the kVp and the MAS, kilovoltage peak, and the milliampere second. These are the electrical parameter that is important to determine whether you will get good image or not. But now we are going digital. We can even if the radiographer, the image is slightly suboptimal, we still can play around with the image. We can make it darker, we can make it brighter, we can make it look like this. Okay, but this is how you must comment on the images. If there's a blackening of the images, there'll be overexposure of the X-ray, and if it's whitening, most of the X-ray are not being given enough radiation, so it will be underexposure. So that's why now we go digital. What I mean by digital is we are doing CR, computer. We are doing DR, digital radiography. Last time we used to do CR, okay, but before that, CR is still we're using imaging plate, okay. But in computer radiography, there is no more dark room to develop the film in chemical trays. Okay, and the image can be viewed and enhanced using software such as contrast, brightness, and zoom. Okay, computer radiography, which means that the CR and DR, the machine is connected directly to the computer. Computer will process the image. That is why for radiologists, if you come to the department, and for radiology MO, they will view the image from computer and they can play around. Okay, I'm going to show you some of this contrast, brightness, and zoom. This is all post-processing the function. And then we have fluoroscopy. The difference of fluoroscopy and X-ray, both uses radiation, but X-ray basically use a static image, static 2D image. Okay, whereas fluoroscopy, we are doing kind of a cinematography, cine, which is a video function, because we want to see how that thing moves real time. That's why, for example, you do your barium swallow, for example, you give patient a drink your barium. We want to see how the contrast flow as the patient keep the contrast inside the mouth and starts to swallow until everything goes into the stomach. We want to see how the movement of the esophagus, for example. Okay, and then that's the second difference. The third difference is actually the machine itself. The machine is different. It does not only have X-ray source. It has a fluorescent screen as well. Okay, and the machine is actually totally different. You can do X-ray image from a fluoroscopy machine, but you cannot do a fluoroscopy procedure using an X-ray machine. Okay, so this is what happens long time ago. Probably this is what happened in the early 1900s. Okay, after we discovered X-ray, this is very dangerous because this is fluoroscopy. You are inside the room with the patient. You are exposing the patient with real-time X-ray, multiple and many shots. Many shots. Okay, the fourth difference apart from the machine is that fluoroscopy. Okay, bila X-ray, when you give X-ray to patient, you press one button, kan, like what you have seen in the ward when they do portable X-ray. Somebody will shout, kan, X-ray, and somebody will press the button, and there'll be one macam camera click. And that's it. That is what we call one exposure, and that is relatively high lah, the dose to get a very good image. And that's what happened in the department lah, in the out. But for fluoroscopy, okay, just now for X-ray, for example, the function is called acquire, capture, which means that memang kita ambil gambar X-ray as in X-ray full dose, okay? But in fluoroscopy machine, it has a function of what we call screening. That's why if you go to fluoroscopy room, there will be a pedal. Okay, the operator, you see if the radiology MO is going to take the image, sebab dia tu macam nak buat video kan. So somebody who wants to take the image must know what they want to take, how the picture should look like, they must know all that. So there will be a pedal beside the operator and he will press it. There's a pedal for acquire or capture button, which will produce an X-ray image, a high dose image. And there'll be another pedal which is for screening. Screening is a low dose. It will give off low dose. For example, kita macam nak positionkan patient kan, nak tengok if you want to see if you want to image the uterus in hysterosalpingogram. The uterus is inside is at the center. We want to adjust the position and stuff. We use screening. When we screen, we give like a pulse, macam pump, depending on the setting lah. If you put like 4 pulse per second, it will give off 4 pulse very fast lah, like that. Okay. Okay. All right. This is just one of the complications that can happen when you are exposed to very high radiation. Okay. So this is again the setup of fluoroscopy. Usually we have a table that patient lie down lah. We do have table for X-ray as well, but usually the baki will be the different setup is actually distinct. I believe every one of you who went to ortho posting, you all have heard of image intensifier. We call it II. Okay, it's mainly it has a lot of use, but mainly used in orthopedic lah, when they do fracture reduction, post implant fixation, fracture refixation and stuff. They want to do check X-ray, and then so there will be a portable fluoroscopy machine that looks like this. This is the X-ray tube that also that we the one that we have in our X-ray machine, but X-ray machine does not have this. It does not have II. That's why I say fluoroscopy can produce X-ray image, but X-ray machine cannot produce fluoroscopy image because it doesn't have the screening function, does not have the video function. I just want to share with you also. I think last year or 2 years back, there was a story that happened something happened in anesthesia in the ICU, whereby an anesthesiology medical officer, she was not aware of the difference of the function of fluoroscopy machine and an X-ray machine. That one of our radiographer, a junior one at that time, went up and was supposed to perform a portable chest X-ray. And at that time, this MO was inserting some nasogastric tube and unfortunately not unsure of the position. And she was asking this radiographer to do X-ray, but she was treating it like a fluoroscopy machine. She asked the radiographer to capture and not screen, capture 17 times of chest X-ray to locate the nasogastric tube, which is absent. Okay, it should not happen because she thinks that it can be done that way. She thinks that a portable machine, X-ray machine, is equivalent to a fluoroscopy machine. She can do that if there is a fluoroscopy machine. Maybe she has seen a fluoroscopy machine in an OT before and she thought that it's the same machine, but it's actually not. Okay, and she exposed a patient to a chest radiograph full dose 17 times, 17. You just imagine. I've never seen anyone having so frequent of chest X-ray in a day lah, except for what that happened at the time. So it becomes an issue to the department. Okay. So this is a modern fluoroscopy suit, as opposed to what you see in the previous more ancient images. The operator must wear a alert gown because he himself is exposed to the patient. There will be a a screen, whatever he capture here will come up here and will decide whether to move this thing up, down, backward, forward, left, right. He will decide. And screen bila when he see gambar cantik je, atau bila macam for example barium swallow ask patient to bring the contrast, then he take the scene image in video form, because because it's a very fast image kan, you see fluid flowing, you see the movement of the esophagus and stuff. Okay, so what do we do? The procedures for fluoroscopy, investigation of GI tract, barium swallow, meal enterophysis. I've never seen this. It's I think obsolete. We still do meal. We frequently do swallow. Okay. Orthopedic surgery, angiogram. We do all the angiograms. Okay. If you're lucky, within the 2 weeks posting, you'll be able to see this. PICC, peripheral inserted central lines. Most of the time they send to us to do. For whatever reason for long antibiotic, for TPN, they will ask us to do. And this one, neurosurgery RPG. On our side, we do APG. Okay, please find out what is the difference. Okay, and then implantation of cardiac devices, pacemaker degree later, and then discography. Okay, so these are the image, pressure reduction. This is discography. This is barium enema, and this is your pacemaker placement. So DSA, just so you know that our machine down here is so canggih. Okay, not all hospitals have this. Okay, because we have Prof. Razali as interventional radiologist who is capable to do a lot of angiographic procedure, especially the therapeutic ones. Macam radiologist biasa macam I ni boleh buat benda simple yang macam diagnostik lah sahaja. Okay. The principle is the same as fluoroscopy. It's just that it has an extra function of digital subtraction. Okay, as the name implies, it's not difficult to understand. As the name implies, digital subtraction means okay. You imagine during the angiogram, usually this is a cerebral angiogram. Usually the indication was to look for AVM, intracranial aneurysm. Okay. What happened in angiogram most of the time when we want to access the artery, most of the time we puncture the right or left femoral artery lah, and then we advance the catheter up to the internal iliac, external iliac, into the abdomen, into the abdominal aorta, into the arch of aorta, and this is cerebral angiogram. We start cannulating for the right common. The subclavian, not the subclavian, the brachiocephalic, the right brachiocephalic, the left vertebral, and the left subclavian. Okay, so this is an example of an image frontal view of, this is a native image. What I mean by native image is, in this instance, Prof. Razali inject the contrast material. This one lights up because it follows your blood flow, but it lights up just for a few seconds only, and then it goes back as normal. And this is what we want to capture. This is why you need to take this image in a video-like form. Okay, but in this image, you see, if you have a very small aneurysm here, it's easily hides in between the orbital bones and stuff, right? So that's why we have the digital subtraction image. Okay, the digital subtraction image, basically it helps you to subtract all the bony structures that were previously there, so that you can only just visualize the vessels of interest. Okay, and by now you should be able to catch any aneurysm or AVM that is present. And this is arch aortogram. Okay, this is your aortic arch. This is just an inverted image of this. And there's a filling defect in between. Okay, and this is your catheter. You can see your catheter. Arch aortogram is usually you need to use pigtail. Pigtail is a very big catheter, usually used to drain collection. But because the volume of blood and the flow is very fast in the arch of aorta, you need a big amount of contrast to capture the image. city. Okay, now we go to city. Why do there is a Beetle group? I do not know if your generation know who is Beatles. When during my time, Beatles, they're not famous anymore, but I still know them. So I doubt that you all know them. But why the image is here is because who invented city machine is actually somebody from the background of electric and musical industry. Okay, Mr. Godfrey Hounsfield, he's still an engineer, medical engineer, but he was previously at EMI, and he won the Nobel Prize for inventing a CT scan. So this is a setup of CT scan. You have the table which can slide in out, can go up down, but it has a maximum weight. Like if you all just came back from NS posting, you know patient name by the name of Akmal. Very pity that patient, a lot of problem, needs a lot of imaging, needs a lot of CT, but cannot be done. Why? Because the table cannot support his weight. Okay, so this is the gantry. You see all this blue thing. This is the detector array. You see this X-ray source, the pink tubular thing here. What happens when the patient goes in? It's like this thing will keep rotating, depending on what they are imaging. Okay, for example, if it's a CT head, it goes from the top of the skull, rotate down to the base of skull. Okay, and it will continue giving radiation, and this is the detector which detects the radiation, and all this information will be computed in the computer, and the computer produce our image. And this is the schematic presentation. Again, schematic presentation, same. Okay. Now, CT. That you need to know some principles. Okay. Basically, this is a chest X-ray. This is a CT thorax. Okay, of different patients because there's a lung mass, right high lung mass over the right side in the CT image, but there's none over the chest X-ray. Is quite clear at this point. The beauty of CT is that it is able to discriminate the different types of structure that you're looking at. How is it doing it? Okay. If you are looking at the plain chest X-ray, you can tell this is bone, this is ribs, this is spine, this is heart. Okay, this is liver. Okay, because you know the location. Okay, but you cannot discriminate the liver, the portal vein from the liver parenchyma, for example. You can't, even if there's a gallbladder here, you cannot discriminate it. Okay, but you can do it with CT. Why? Because of the grayscale. You see the grayscale on the radiograph and the grayscale on the CT. If you notice, the grayscale on the CT is more variable. You see more shades of grey, Okay, grey start dari sini kan, more long daripada sampai black kan. As opposed to this one, grey tu kat sini, grey to white here. So it's a shorter range of shades of grey. Okay. And if I've heard it in our workstation, okay, can you see my workstation? Oh, you can see my workstation. I'm showing you this is my workstation. This is how I manipulate the image. This is a CT image of my on-call case yesterday. Okay, that's plain, that's contrasted. Thick slice because there's a 5 mm here, and then kalau thin slice 1 mm. Okay, I can right click, I can have a look. This is just for you, just to delight all of you lah. Okay, right click, I put a measurement, I put it like this at the liver parenchyma. Okay, the average is about 109. This is the Hounsfield unit, minimum 48, maximum 160. If I put at the same region, around this region, but this is plain study, which means that the liver is not enhanced by contrast. You can see that the density is very much low. 47. So this is the Hounsfield unit. Okay, as a structure is more dense, more opaque, like bone, the density increases. And you can have an idea if you see a density whether it's metal or is it bone. You can even discriminate it to that extent. For example, if I put here bone, again you can put here, it's about 250, the density as compared to the liver 47 only. And then this is liver plain, no contrast. And then I'm interested with the omentum, probably the mesentery, or the subcutaneous fat. If I put my ROI here, fat is always negative. Okay, you see negative 90. That's how you can discriminate the structure. Very nice, isn't it? And even soft tissue and fluid field structure cannot be differentiated on X-ray, but in CT we can discriminate it very well. For example, this is your Foley's catheter balloon, okay? Because the bladder is not so well distended, so I cannot show you the urine density. But the balloon is usually filled with your saline, right? So again, do the ROI, put here. Fluid, if it's a clear fluid, is usually around 10, less than 20. Less than 10, less than 20, like that. So this is 11. Okay, the saline within your Foley's catheter. Okay. So this is the CT number. I've told you just now, bone is about 100, liver about 40 to 60. Water, pure water, nothing at all. It's supposed to be 0 lah. But probably if there's a line, there's something else within it, macam a bit turbid cover, the density will increase lah. And fat is always negative. And air here you put it -1000. You don't believe the graph? Just do here. Negative 998, close to 1000. The air surrounding the patient is also being irradiated by the CT scan. So, okay, this is just illustrating the same thing. And you know, in this this is what we call workstation. Okay, this is how we report day to day. When you come to the department, you can always ask some of the MOs, or even during class with the lecturers, you can ask them to show you certain things, because some of this cross-sectional image, the in axial view, will come out during your OSCE. So you can always ask to have a look at them. We can enlarge the image. We can play around with the density. You want to make it dark. You want to make it bright. Okay, you can always change it. Okay, we want to make it into 3D. Okay, 3D, of course you can. We choose a thin slice. Kalau thick slice nanti dia nampak macam tangga. Okay, and then you put it. So this is your MPR, or multi-planar reconstruction. When you have something to see in more detail. Okay, yeah. So basically, CT has the capability to produce all this kind of image. So mammography, you know what it is for. Please make sure that you know when to screen somebody. Usually after 40, and most efficient screening method. And in SUSMAC here we have breast tomosynthesis. It is an additional 3D breast imaging. So on top of the 4 images, CC and MLO left, right, that we produce for each patient, 2D, we have tomosynthesis that allows us to scrutinize the image better. Okay, this is just an image of a excision of a breast lump using a hook wire localization. Okay, nuclear scan. Nanti we'll have lecture on this, but just know the principle that as opposed to all the modalities that I have explained to you, whereby the radiation comes from the machine to the patient, there'll be some form of detected trying to detect that and convert it into image, right? But this is different. This is a different concept. You inject the patient with the radiation, and then it follows all the physiology of the flow of the blood, and depending on what type of radiotherapy you're giving, the one that will reside in the thyroid, the one that will reside in the kidney, you can evaluate certain organ of interest. Okay, and this gantry, what is it for? This is the detector. This is the one that will capture all the radiation emitted by the patient. Okay, so this is bone scan, this is ventilation perfusion scan, your thyroid scan, this is your RBC scan. And now we have a combination of CT with PET to further, we do not have it here. Kalau patient nak kena buat PET, CT selalu kita hantar KL lah, IKN, ke mana kan, we do not have it here. The concept is similar. You inject patient with radiotracer, selalunya apa? FDG kan, fluorodeoxyglucose kan, because nama dia ada glucose. So it will be taken up by a hypermetabolic pathology process, infection ke, tumor ke, it will light up because a lot of metabolism going here. So we correlate. This is with CT. Okay. Any question? I'm going very fast, but you do not need to know all, but make sure you have your basic and your principle of X-ray correct lah. Any question? Tak ada. Semua penat.
Tak ada so far.
So far tak ada. So after this, you all go back to your mahalah lah kan? You are not going back to your clinics or whatnot then? Instrument then. Okay, so kalau tak ada apa-apa, who haven't seen me, I hope to see you in the department. Welcome to radiology. Salam Ramadan and happy breaking fast. And we close our session with Tasbih Kafarah and Surah Al-Nas. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.